friends from the North.
Not yet, I think.
Okay. You want- Hi, hello, my friends from the Asian Oceania regions. Good evening, and also good morning, my friends from the North America. So I would like to welcome you guys to the AsiaSafe webinar series. So this is a series that we are going to talk about enhancing optimization strategy in radiological practice. And this is the third webinar on this series that we are going to talk about the optimization in the IR, talking about tools and technique. My name is Nucharin Tanya Supakor, one of the Asian Saver from Thailand. And today it is my great pleasure to have Dr. Jamari Chiapechara-Sopon, who is the president of the AOSR with us for give us a welcoming speech. Welcome, Dr. Jamari.
Thank you, Dr. Tanya. Okay. Welcome, everyone. It's a pleasure to have you with us for the third episode of the OSR AsiaSafe 2025 webinar series. Today, we shift our focus to a key area in radiological safety, optimizing those in interventional radiology tools and techniques. We are honored to have Professor Samuel Brady continuing with us and delighted to welcome Dr. Edward Chan from Hong Kong, who brings valuable regional expertise to today's discussion. Let's explore practical strategy to enhance safety while maintaining procedural excellence. Thank you for joining us. Let's start.
Yes. Thank you so much, Dr. Jamari. And I think this is going to be one of the fun session that we have the medical physicists, also technologists, and you as maybe part of the like a formal trend in the body intervention with us today too. And let me share my screen on the what we are doing today here. Yep. Okay. Yeah. So this is the third webinar series episode on the IR. And let me introduce our speaker, Professor Samuel Bradley from the Cincinnati Children's Hospital. He is a chief medical physicist there and also part of the fellows of the American Association of the Physicists in Medicine. He has a lot of international experience, including part of the IAEA expert that help several countries on the establishing the DRL and also part of the international speaker for the Imaging Academic Outreach Center that talking about the medical physicists, radiation safety, and imaging technology implementation. And he also is a member of the IEC committee that developed the technical standard for the safety performance of the CT medical equipment around the world. He is also the vice chair of the Imaging Lead Alliance, also chair of the ABR Radiologist Examination on the medical physics, and also chair for the AAPM Annual Meeting Education Program Working Group, and also the member of the AAPM Ad Hoc Committee on the Artificial Intelligence. And our next speaker is Mr. Edward Chan from Hong Kong. He is a director of the professional practice of the ISSRT. He also a president of the Hong Kong College of Radiographer and Radiation Therapists, and also a senior lecturers for the Health Science Hong Kong Metropolitan. He got a master degree in psychology and healthcare, and also the certified professional in healthcare information and management system, and chairman of the Hong Kong Radiographers Association. He is part of the exam committee member for the radiographer boards in Hong Kong. So today we're gonna have this a speaker, distinguished speaker for us. And before we go to the lecture part, I would like to introduce you. I know that you guys already registered on the VDoctor, so we can see you can see the webinar right now. But if you can just type your name when you join the VDoctor, you need to type your name. So by that way, you can ask us the questions, put the questions in the chat box, and get the evaluation link on the chat box. So when you log on to VDoctor, you cannot just watch. You need to like type your name. It can be fake name if you don't want anyone to know your actual name but you can just put the name there. And then you can scan the QR code here as an evaluation form, because by the end of this webinar, we want to know what we can do better in the future, or what topic that AsiaSafe can serve you better. So please scan the this QR code, and give us a feedback on what we are doing and what we can do better. Yep. Okay. And from now, I would like to welcome Professor Samuel Bailey for his talk. Yep. Welcome,
Thank
Sam.
you.
And
Welcome.
congratulations.
I'm so grateful to be back with you all. I'm going to share my screen now. It's a pleasure to be with you again. And I have always enjoyed talking about physics, but talking about interventional radiology is something unique. And when I say interventional, I'm generally talking interventional procedures. So we can talk about IR, and we can also consider cath labs in cardiology. I'm going to largely focus my discussion today on patient-centric or patient-facing safety, and not really talk much about staff safety. But one truism that we can always remember is, if we keep the dose low to our patient, we're keeping the dose low to us as the staff. All right, so when it comes to optimizing our interventional systems, there are a lot of features that we need to consider. But the interesting thing about considering all of these features, such as the output of the machine, the field of view, the patient size as it affects patient dose, using last image hold filters, the KV, the MA, the pulse versus continuous, all of these features, if you actually play the game and try to connect the dot between patient exposure and image quality, there actually isn't a direct link. In other words, when you think about our best way to get image quality and good patient dose, this actually has more to do with how you use the machine than what we can do on the back end to fiddle the dials and to type in different settings. And so fluoroscopy safety is quite literally in your hands. So what are a few things that we can control that have a very direct impact on image quality and patient dose? So I'm going to spend my talk today talking about detector selection, collimators or collimation, use of grid, the couple of different modes of operation, such as magnification mode and our pulsed versus continuous mode. And then I'm going to talk a little bit about how the automatic exposure rate control works and how that can affect patient dose and image quality. So when it comes to the actual detector, for a very, very long time, we have been using image intensifiers. I wouldn't be surprised if a lot of the systems you use still to this day use image intensifier detectors. But recently, more of the newer systems, they've been transitioning to using flat panel digital detectors. There are pros and cons on the use of both of these detectors. And so to demonstrate some of these pros and cons, there is a kind of a fun way to look at the use of the detector. So this is a kid's toy, and we put up a little track on top of the detector, and we turned it on, and the car just drove in circles around and around and around, and it was sitting directly on either the II or the flat panel detector. We put some plastic here. You can see this acrylic plastic here. That's largely there just to create scatter, so it emulates more of a patient image. Now on the top, you can see this first column was acquired using an II system, an image intensifier. The next system is a flat panel using indirect conversion technique. So the X-ray comes in, interacts with the scintillating crystal, creates light, and that light is what is collected to create the image. And then finally, another flat panel detector, but this one uses direct conversion, where the X-ray comes in, and that X-ray will then generate electrons, and the electrons are what are collected to create the image. The middle row represents the car captured in real time while it's moving. And then the bottom row represents the car when it's turned off and just sitting stationary on the detector. And when you look at this combination, so you can kind of look across the rows, you can see here how when the car, the toy is in motion, the II actually does a really good job encoding the image compared to the flat panel direct conversion detector. And then when it comes to a stationary system, you can see that the flat panel direct conversion actually is the best looking image. So there's trade-offs between these two systems. And when you consider motion as a surrogate for fluoroscopy, you can see that the best is II, second is indirect with the flat panel indirect version, and then the worst is direct. But when you consider stationary imaging that we do in fluoroscopy, the best option is the direct conversion, then the indirect flat panel conversion, and then the II is the worst. So interestingly enough, most fluoroscopy systems today are going to be one of these two things, with the most modern systems, as I mentioned, being flat panel. And the flat paneled systems are now indirect. So this is a trade-off. You can see that they scored 2 both times for moving and stationary imaging, but it's a trade-off. It's a happy trade-off compared to II systems that are ranked either best or worst. You can buy these direct conversion flat panel systems, but they're only currently offered on mobile C-arms. So the second thing you need to consider when picking a system to use is the size of the detector. They come in a variety of sizes, but generally small and large. Now, a small detector is really good at rejecting patient scatter because it's got a small area. And that small area just doesn't collect all the radiation. And so you can get really good contrast in the image. And this is why we often use it for cardiac imaging, because we're only imaging the heart, so it's a small field of view anyway. Obviously, the trade-off is if you do a small field of view, you won't cover as much anatomy. So it might be harder for the interventionalist to work. And that's why we still often see these large area detectors used, especially in interventional radiology. The next thing you can control is the collimator. This is really some of the most simple technology on the system. But when you're imaging with fluoroscopy and you directly expose the detector itself, this changes the dynamic ratio. The white to black area is now going to be somewhat muted, and there's going to be a lot of gray in there. But when you collimate and get rid of that direct white, you can see that now there is a lot better dynamic range. The blacks and whites are more distinct. And so you see the contrast, at least in this bony anatomy, much more. So the key here is always collimate to the area that you're using and only that area. This is best for image quality. And of course, it reduces the amount of dose to the patient. And because the area is smaller, it generates less scatter. Less scatter means less dose to you, the operator. Now, most of the modern systems use something called virtual collimation. So you can push on the pedal, you collect the image, and when you let go, you'll get the last fluoroscopy image hold. And so you'll either have that constantly looping fluoro from the last fluoro run, or you'll have a stationary image. And then if you apply the collimator, so you set the collimators, change the area using the collimator controls, these dashed lines will appear on the image. And they're showing you where the collimator blades are with respect to the anatomy. So the next time you step on the pedal, you can see the image is already collimated. This is a simple way to reduce dose to the patient instead of collimating under active fluoroscopy. Now, we can't always use virtual collimators, or there are times where we just simply can't collimate out the image because we actually need to see in this part, this anterior oblique area of the heart, in which case we need to then use wedges or equalizing filters, and that will help because of the shape of the human body, and it will optimize or equalize the amount of radiation used throughout the entire field of view. So we can't always collimate, but these wedges and filters will also help the image quality and actually reduce dose a little bit to the patient. All right, you've probably all been taught to use grids. Grids help reduce the image noise because it prevents scatter coming off of the patient. And so we're always taught to use grids for all cases. But for those of you that do pediatric imaging, you oftentimes are told remove the grid when imaging little kids because they don't need a grid. Problem with that, especially in the interventional suite, is once the system is draped for sterility, it's really hard to remove the grid. And so should we remove the grid for pediatrics? The answer is generally yes. If you remove the grid, it reduces the dose to the patient. That's something we call the Bucky factor. You probably studied that in school. However, when you remove the grid, even though these are teeny babies, maybe neonates, you still increase scatter on the image. So we did a study where we took 3 little piglets, actually piglets of different sizes, and we imaged them with a grid and without a grid. And so these are baby-sized pigs. And what we wanted to do was count the number of branching ratios, levels, 1, 2, 3. How many branching ratios can we visualize before the image becomes non-diagnostic? And so when we look at the grid, the scenario where we took the grid out when imaging those piglets, we saw the dose was reduced by 26%, which we expected. And that's a good thing, right? But we also saw that the scatter increased by about the same amount. And that's why you can see without a grid, you really do lose the ability to count down to maybe the 3rd branching level. You can see maybe 3, definitely not 4 branching levels. And with the grid, you can see that the quality of the image is just a little better, and you definitely can get 1, 2, 3, maybe even a 4th branching level. So the interesting thing that we learned, is that if your task is to be looking at the really fine vasculature in the image, then you really should keep the grids in. Even though it does require a little bit more dose, it reduces the noise, so it keeps the image quality appropriate. And the right dose for the patient, the dose that you need for the patient, the right one, is the dose necessary to perform the diagnostic task. So don't be afraid if the dose goes a little higher, as long as you can work efficiently and provide the medical care your patient needs. All right, magnification modes. It depends on the type of detector as to how the dose affects your patient. For the image intensifier, when we go from non-magnified up to, say, Mag 1, Mag 2, etc., we are going to see a better spatial resolution, right? Image intensifiers, when you magnify the image, it uses smaller and smaller fields of view, and so it really enhances what you can see. But the problem with that, as you go from using the full detector with no magnification to a small area under high magnification, this requires an increase in radiation dose to keep the brightness on the monitor. If you use less area of the detector to collect X-rays, you collect less X-rays. It's like a bucket collecting water, right? Small little cup versus a big bucket, they obviously collect different amounts of water. It's the same analogy when collecting radiation. So as you increase the mag mode with an II system, radiation exposure goes up to the patient. You all know this. You've been dealing with this for years. The nice thing about this is historically, so if you're using a system that was built in the 80s or 90s, when you go from 0 magnification to higher levels of magnification, historically the dose increased quadratically because we had to square the difference of the input versus the output. So it moved quadratically. But today, and that was back in the day when they used a fixed iris at the back end. This iris back here was fixed, and so it collected the same amount of light every time. Nowadays, we use dynamic irises. So if you go from a large field of view to a small field of view, the iris gets bigger on the backside. And that means the dose now only increases linearly. So it's okay if you do need to go up in magnification on a modern system, one built usually in the 2000s or 2010s and above. It's going to most likely have a more linear response to dose, not a quadratic at these high mag areas. All right. If you have a flat panel system, and that flat panel system is being used to do the magnification, because of the larger area of these flat panel detectors, what we have to do is something called pixel binning. And so normally the digital detector has all of these little electronic elements, and they collect X-rays, and that's what creates the image. But when you go from large to smaller and smaller fields of view, what happens is at the very large fields of view, you need to take and bin or combine multiple of these elements together to create large ones. And this is the same analogy of our bucket versus cup to collect water. If you have a cup collecting water, it's going to take a lot of radiation to fill that cup up to create a good image. And a large field of view creates a large size image, hundreds of megabytes. And that's hard to do in real-time fluoroscopy. So these large fields of view, they use binning. And that binning will reduce the noise, which is a good thing, but it'll reduce the spatial resolution. Now with binning, excuse me, with the digital binning, it also is able to keep the dose pretty low. So when you go from these large fields of view towards the smaller fields of view with flat panel digital systems, we actually don't really see a large change in dose. And that's why you can change your field of view without really affecting patient dose. What does change because of the binning is the resolution. So this solid black line right here represents the resolution that you will be able to visualize. Because of pixel binning with the large fields of view, you get less resolution. Now, when you go to smaller and smaller fields of view, the pixel binning goes away, and so you get better spatial resolution. And if you compare that with these dashed and other solid line right here, this is from an II system. And those, as you change magnification and fields of views going from large to small, you can see that the resolution continuously increases and improves. So it's a small trade-off going from an II system to a flat panel system. And just understand that when you're using large fields of view on a flat panel system, the image resolution will be slightly less than at the higher or smaller fields of view. All right, the other trade-off is, so we talked about dose, we talked about resolution, it's the noise. Even though when we go from large fields of view to magnified smaller fields of view, we can reduce the noise in the image. The interesting thing is, because it's digital, you see the image bigger on your monitor. And so the noise itself will appear differently. The texture changes slightly. And that is why at larger magnification modes, we have to use a little bit extra dose with flat panels so that the noise doesn't bother the interventional radiologist using the system. And so the noise will change just the way it looks a little bit on flat panel detectors in the smallest fields of view at the highest magnification modes. But once again, it doesn't really change the dose too much, just a little bit compared to II, which changes linearly. All right, another thing we can control is the modes of operation. One of the not easiest, but one of the most frequently changed things is if we use pulsed fluoroscopy versus continuous fluoroscopy. So here you can see I have these two dials. They have numbers written on them, and then they have each number corresponds to a different thickness wire. Those are actual piano wires. And the thinner the wire, the harder it is to visualize in motion. Now, when we have historically used continuous fluoroscopy, we have collected 1 second worth of imaging, and during that 1 second of image, we've collected 30 images. So you do the math, that's about 33 milliseconds per image collection. And that means if there's any motion during that 33 milliseconds, it causes blur in the image. Now, for pulsed imaging, now we're only collecting an image for something like 5 to 20 milliseconds, so very short. We still collect the same 30 images for a 30 pulse per second acquisition, but we've sampled it. And if you're only collecting 5 milliseconds instead of 33 milliseconds, you don't see the motion. And so pulsed fluoroscopy does reduce dose of the patient, but it's also amazing at reducing motion artifacts. So you can see the image sharply. Today, we don't really use continuous fluoro, or you probably should consider using at least pulsed fluoro. Now, the other thing about pulsed fluoro is the fact that our eye can only see about 30 frames per second. And that means 6 frames, on average, 6 frames will be put together or averaged, and that's what our brain will see. So our brain acts as a noise filter, and that allows us to get away with fast-moving objects without a lot of noise in the image. But because of that, if we go from 30 pulses or 15 pulses or even 7.5 pulses per second, we need to increase the radiation dose to each one of those individual pulses because our eye wants to group 6 images together. And once you get down to, say, 7.5 or 6 pulses per second, our eye can't average anymore. There's not enough information to average. And so what we do is we take and we increase the amount of radiation per pulse. And if you can see here on the top of this plot, we have continuous imaging. So if you, for one image, what would be 33 milliseconds, you can see the overall MA is very low under continuous mode because it's on the entire time. But for pulse mode, what we're going to do now is we're going to take that same amount of MA, but we have to acquire in a very short time, say 5 milliseconds. It's the same amount of MA, just acquired in a short amount of time. And if we go from 30 pulses down to 15, we have to increase the amount of MA in that pulse to reduce the noise. So let me demonstrate this. Here I have we're under fluoroscopy. I have a watch or a clock that's ticking away. So on the left, you have 30 pulses per second at a particular dose. And then on the right, now you have 7.5 pulses per second. The image on the right most likely looks more noisy to your eye because the dose is the same. The dose is the same per pulse. Now, the patient received less radiation total because you go from 30 pulses per second to only 7.5. We're not imaging the patient that often, but the image is noisy. Now, what I did here in this image, same image on the left, 30 pulses per second at a specific dose, X. Now, at 7.5 pulses per second, I increase the dose per pulse. It's 2 times. So here, if you look at the noise on the right side is actually probably better. Yet the patient received still a reduction in dose of half. So 2 times reduction. That demonstrates that if you put the dose if you balance the right amount of dose per pulse, the operator, will see good images with not as much noise, and the patient will still receive less dose. This holds true all the way down to 6 frames per second. Anything less than that, if you're operating at, say, 4 or 3 or even 2 pulses per second, you don't want to keep adding doses per pulse because our eyes don't integrate anymore. And so anything under that, here is an example, 1 pulse per second on the left and 7.5 pulses per second. You can see that the dose is very low. The patient reduction dose is 7.5 times lower, which is great, but the noise itself is equal. And that's because our eye doesn't average anymore each of the frames. All right, so let's talk about the automatic exposure rate control. Now, when you turn on the system and you pan, so you're sliding the table in and out over maybe a very thick part of the body, such as the pelvis or abdomen, and maybe you slide towards a thin part, maybe the upper thigh, or you go towards their chest and maybe they have a smaller chest, the system will change the radiation output. You've seen this, right? And that's because the automatic exposure rate control is constantly optimizing between pulse width, the focal spot size, the filtration in the image, MA output and KV output. And it always wants to try to keep the shortest pulse width to keep a sharp image, the smallest focal spot size, once again, to keep the best resolution, the largest filter to reduce skin dose, the lowest MA and KV to keep patient dose low. So that is the default setting. It's always trying to operate all the way at the left of this scale. But that's true really only for small patients. So what happens when you put a larger and larger patient on the table, or you pan from a small piece of anatomy to a larger piece of anatomy? Each one of these systems is going to change. Now, you can see here that as you go from small to large, the MA changes probably the quickest in each one of these plots. And that's because system is always trying to keep keep KV the same, keep the smallest focal spot, and keep the smallest pulse width so that the image will have the best resolution at the lowest dose. Sorry, I meant to push the button. That's what I just said right here. You want to keep KV the same because KV controls the image contrast. You don't want to change the contrast like this exponentially, because then the contrast, you would go from being able to see the iodine that you just squirted into the vasculature, or you wouldn't be able to see it. So you want to keep the KV largely the same. All right, I talked about pulse width. Now this is kind of confusing. Pulse width is different than pulse rate. So pulse width refers to the amount of time the radiation beam is on. So during pulse fluoroscopy, we're capturing for a very short amount of time, maybe say 5 milliseconds, the amount of radiation we need to create the image. Now, as we get thicker and thicker parts of body, there comes a point where the generator just can't produce enough MA. And so once it hits its maximum, what happens is the system then has to widen the width. It has to stay on longer. So instead of 5 milliseconds, maybe it's on for 10 milliseconds. Well, obviously, the longer the width is on, the pulse width is on, the more image motion is encoded and used for the image reconstruction. So when you consider using pulse width, the thicker filters or thicker bodies require higher MA. And that higher MA generally requires a larger focal spot size. And that usually requires a wider pulse width. So bigger and bigger patients are you're going to start to see possibly a little less image quality because of motion degradation in the image. We recommend, generally speaking, that if you can control, so you talk to the vendor when you're installing the system, when you're doing pediatric imaging, to have the pulse width around 5 milliseconds. So 5 milliseconds wide. And the adults, just a normal average adult, really should be somewhere around 10. And then for very large patients, of course, it has to get wider, up to maybe 20 milliseconds. So here's an example. Here, I'm zooming in, and you can see the wires in the image and the numbers corresponding to the thickness of the wire. The image on the left is 2.5 millisecond wide pulse widths. Image on the right is 7.5. And now on the 2.5, you could probably see 3, 4, 5. You can see all of these different wires. But on the wider width, you can see 3, probably 4, 5, maybe if you're lucky, but it's hard to make out. And that's because it's the same amount of motion, same amount of speed of this rotating object, but because there's a wider pulse width, you're collecting more image motion, and so it degrades the image. So we want to use the shortest pulse width. The other thing you want to do when you're purchasing a system is make sure it comes with grid control. So every time you push the pedal, there's a finite amount of time that the system has to heat up, turn on the MA, eventually you get the right MA, and then when you let go of the pedal, there's a point where it just takes to get all of the MA out of the tube. And these tails on the beginning and end, we call them ramps or tails, they provide excess dose to the patient. Under grid control, the system will actually always have MA current flowing, so it's always on. And then when you push on the pedal, it will release those the X-rays that are sitting in the X-ray tube. They'll immediately fly off to hit the target or the anode. And so there's not really any ramp up. And the minute you turn it off, it uses a magnet to cut off the electrons instead of letting the electrons just fly through the system. And so it's a really good, this grid control way is really good at reducing these tails, keeps the dose to the patient low. Filters. We can control how much filter is in the image. Sometimes you have to work with the vendor, the manufacturer, so that if you have particular patient sizes or protocols built into your system, that you can tell it which thickness of filter to use. Generally speaking, most people use copper filters, but you can use aluminum, and some vendors will use different elements like silver or tantalum. But for all intents and purposes, they do the same thing. The filters in the system reduce the overall skin dose, and that keeps our patients safe. Obviously, the higher amount of filter has the potential, once again, to reduce spatial resolution because we use wider pulse widths and focal spots. So you don't want to always use the thickest filter. You want to use the right filter. Sometimes it's usually going to be somewhere around 0.4 millimeters of copper. And that's kind of the sweet spot that we use in pediatrics. It's just thick enough to help keep the dose to the skin low, but it doesn't reduce the resolution. Some systems will go all the way up to 1 millimeter of copper, and that's a lot. All right, where do we put the detector? So we've talked about picking between II and flat panel, but if you keep the detector close to the body, that's another great way to reduce the scatter coming out of the patient that strikes the detector. So if we keep the detector as close as possible, this improves the contrast to noise ratio in the image. But it also keeps the dose low to the patient, which is a good thing. The farther you pull the detector away from the patient, the higher the dose would be for the patient. And then thirdly, if you keep the detector close to the body, it keeps the image sharp. The farther away a detector is from the anatomy, the more blurry the image is. So if you're far away, this is how the letter B would appear. If you're closer, this would be how the letter B would appear. So the closer the detector is to the patient, the better the sharpness in the image. And finally, obviously, you can kind of see that if you're the operator standing bedside, then the lower the detector, it actually acts as a protection for you. It reduces the amount of scatter that strikes you, the operator, keeps you safe. Just a couple more things to talk about. When you consider II systems, image intensifiers, they have the typical artifacts, such as the distortion in the image. We call it either a pincushion or a barrel. It distorts the image at the edges. Or you can see straight objects that will actually have a distortion. They look like an S, like the letter S. In flat panel imaging, none of these artifacts exist. And so one of the benefits of using flat panel detectors is you never have distortions in the image that you did have in II. A good practice to always use is to make sure that when the last image hold comes, that when you let off the pedal, you use the last image hold to plan your next steps. Last image hold, even though it's the previous last fluoro run and whatnot, it's a good way for you to stop and think about what you need to do next. Instead of pushing on the pedal and thinking the whole time, that's adding dose to the patient while you're considering your next move. All right, last image holds tend to be noisier because it's usually just the last image or two. Sometimes some systems will take the last 3 or 4 images and average them together. So don't be worried that the last image hold up there is noisier than the actual fluoro image that will happen the next time you push on the pedal. Hopefully, it'll still provide the right amount of image quality you need so that you can plan your next steps. And if it doesn't, you can actually change the settings in the system so the last image hold will have a higher image quality by averaging more frames together or making sure the dose per pulse is properly set. A word or two about dose. So how do we measure dose in the system? The DAP or cap is measured by an ion chamber that sits directly on the X-ray tube. And so that's the value you see up on the monitor. This is a really good way to estimate the total dose and risk to the patient. So when we think about stochastic effects, such as cancer risk, we use the cap or DAP to estimate higher cap, higher DAP, higher risk. But the cap does not help us understand what the risk is to the skin. We need to use the cumulative error curve for that, and I'll talk about that next. So cap is the same no matter where. If you put the patient at the position A, B, or C in this imaging chain, cap will always be the same, and that's because as the radiation leaves the X-ray tube and goes to the detector, the radiation is stronger by the source, but the area that it's passing through is smaller. And you get closer to the detector, the area gets bigger, but the amount of radiation per area is smaller. And so it actually balances out. This is called that inverse distance law that we deal with. The farther away from the source you are, the less radiation strikes you. You need to also remember that every unit is different. If you have a Philips, a Siemens, a GE, they may have different units. Most will say gray per centimeter squared. Some may say mellogray or microgray meter squared. So be careful when you compare the cap values if you have different systems in your interventional lab. I mentioned to you that the cumulative error curve, which is that error curve value listed on the monitor, that is the value that we use to estimate patient's skin. And that's because it's measured 15 centimeters towards the X-ray tube from the system isocenter. This assumes that you have basically a 30 centimeter thick patient, which isn't always true, but it's a very good estimate for the radiation dose that we actually see. So here's a classic example. You have your cap or your DAP, and then you have your error curve. Cap or DAP, that is good for estimating total risk, like cancer risk. Error curve is really good at estimating skin dose. But know, as I mentioned, that value, that reference point, it's 15 centimeters for isocenter. And so if you rotate around, or if you have a bigger or smaller patient, sometimes that reference point isn't actually at the level of the skin. So it's only an approximation. You still actually need to do a bunch of math to figure out what the dose is to the skin. I'm not going to go through this. I'm just telling you that if you really want to know what the skin dose is, the peak skin dose, you have to take into account the error curve value, but you then have to take into account actually the size of the patient, where they are, if the table's high or low, then you have to apply some correction values. So it's a good approximation, but if you ever are concerned about skin damage, then you need to do the math to decide if it really was a dose high enough to cause problems. If you don't want to do the math, just remember this. Instead of staying at the same place at the whole time you're doing the interventional procedure, if you move around the field of view, that will reduce the dose to the skin, as long as there are not overlapping field of views. As the field of views don't overlap, you're distributing the dose and you're keeping the skin safe. Fluoroscopy time is shown on the screen, but the fluoroscopy time is not a good metric to estimate dose to the skin or risk from cancer later in life. And that's because fluoroscopy doesn't take into account the time metric, doesn't take into account any of the parameters like MA, KV, output, any of that. It's just an estimate of how long the time machine is on or off. All right, finally, if you're looking for what is a good dose versus a low dose, that diagnostic reference levels that we talked about several months ago, there are some publications. This publication specifically came from the Asia-Oceanic area, and they gave some examples of typical dose reference levels for, say, a cerebral angiogram, or let's see here, an embolization study. And so this is a good way for you to kind of understand what the right cap would be before you exceed the 75 percentile. If you want to see more listed, more procedures, you'd probably just need to look around. There are lots of countries, either in Asia or around the world, that have published values that will give you dose reference levels so that you will know how to best operate at a safe level for your patients. And with this, I thank you for your attention, and we can do questions at the very end.
Thank you so much, Sam, for bring us to the background of the physics on the fluoroscopy and also like the IR technique. So we're gonna keep the questions for the end. And the next speaker is Mr. Edward Chan from Hong Kong, who is going to talk about like the clinical applications on what we can do on the in the IR suite. Welcome, Edward.
Hi, thank you. Good evening, good morning, and good afternoon to all the audience. So,
Yes.
welcome to my presentation on interventional radiation safety and management, where we focus on optimizing those in the DSA procedures. This initiative is led by a dedicated radiology team from the University of Hong Kong Shenzhen Hospital. Today, we will explore how a continuous quality improvement model can significantly reduce patient radiation exposure while maintaining diagnosis efficacy. Our study details a structural approach driven by frontline staff to implement effective radiation safety measures by combining real-world data, rigorous methodology, and a culture of accountability. This project showcased the power of the radiology innovation in enhancing clinical outcomes and staff safety. Okay, let's begin with an overview of our work. So this study was a self-initiated project. My colleagues and I do not have anything to disclosure. Here is an overview of the structure we will follow in this presentation. First, we will introduce the content behind our quality improvement initiative, detailing the equipment transition.
Edward?
Okay, can you hear me?
I'm
Yes.
sorry to interrupt you. This is Sam. If you're sharing slides, we're not seeing them.
Okay, let me check it.
Yes.
I see it.
Oh,
You can
good.
see?
Good.
Mhm.
Good.
Okay. Okay. Can you hear me, right?
Yes, I can hear
Yes.
you and I can see your slide.
Okay.
Yep.
Okay, I continue. Yes. So okay. So first we will introduce the content behind our quality improvement initiative, detailing the equipment transition and the significant radiation concern that's triggering this project. With the walkthrough of our improvement plan, we will emphasize the PDCA cycle to address the dose reduction impacts of our intervention. To address the dose reduction, we will then present our findings in detail and highlight key statistic impact of our interventions. Finally, we will discuss the implication of our works and reiterate the importance of interventional radiology. Let's dive into the introduction and gain a deeper understanding of our critical work. So in July 2017, the hospital introduced its first biplane digital subtraction and geography system, mainly for the cardiology procedure. Previously, a single-plane DSA system had been used for all interventional cardiac procedure. Radiographer digitally records the total radiation dose for every DSA-guided intervention, ensuring consistent data collection from the outset. Within 3 months of adopting the new biplane system, a concerning trend emerged. The average radiation dose per procedure was 1.7 times higher compared to the old system. This is a statistically significant increase. Despite the technology advancement, the exposure level was unexpectedly high. In response, a dedicated DSA quality and safety task force was formed. Radiographers lead the efforts to analyze the issue and establish a structural continuous quality improvement projects to reduce patient radiation dose without compromising the procedural efficiency. To address the high radiation dose observed with the new biplane DSA system, our team adopt a continuous quality improvement strategy using the PDCA cycle. This structural approach provides a clear pathway for identifying, implementing, and evaluating improvement. During the planning phase, we construct a root cause analysis and identify several operator level and equipment-related factors that's contributed to excessive dose. We then define appropriate remedial actions. In this execution phase, interventions such as operator education, procedure standardization, and visual reminder were introduced. The team collected dose matrix across all procedures. Finally, we used the dose area products as a primary variable to compare the result before and after the intervention. This allows us quantifying the effectiveness of the change and guide the next step in our quality plan. In the planning phase, we conduct a comprehensive gap analysis to pinpoint the primary contributors to increased radiation dose. This analysis was structured using a fishbone diagram, which is a very common tool for the root cause analysis in the healthcare quality improvement. One major issue identified was the operator inexperience. Many staff members were unfamiliar with the bypassing system interface and optimal use. This often leads to suboptimal parameter settings, resulting in unnecessary radiation exposure. We also find the problems related to the consistency of image field and foot-eye coordination during procedures. Lastly, the system complexity presents a steep learning curve for operators. This finding guides our next step in education, system reminder, and procedural optimization. During the execution phase of our CQI plan, we introduced several targeted interventions to reduce radiation exposure. One of the most crucial steps was conducting dose control training for all personnel operating the new bypassing DSA. This training focused on the proper parameter selection, awareness of exposure setting, and how to utilize the system capability best. In parallel, we revisited and optimized the procedural protocols and tailoring default parameters and sequence to minimize unnecessary dose, just like Professor Brady said. To reinforce this practice daily, we install visible reminder near the DSA system control panels and monitors. This prompts action as a quick visual cue to maintain safe radiation practice during every procedure. With the intervention in phase, we transition to the check phase of the PDCA cycle. This involves systematic monitoring and data collection over a 3-month pilot period to assess the real-world impact of our actions. Preliminary analysis show a statistical significant decrease in radiation dose administered, validating the effectiveness of our approach. However, quantitative data was only part of the picture. We also sought qualitative feedback from the operators. Their insight helps us understand how the new protocols were being received and applied on the ground. Additionally, we identified the examined case with an unusually high dose. This investigation provides context-specific lessons and lead to further refinements of the protocols. This phase laid the groundwork for refining and standardizing our intervention across departments. In the final phase of the PDCA cycle, we focus on the embedding successful practice into routine operation and sustaining the improvement achieved. We reinforced the visual reminder system, place clear prompts around the DSA, place the clear prompts around the DSA control areas. These daily cues help staff maintain vigilance in dose management. In parallel, we institutionalized mandatory radiation safety training for all new operators of the bypassing system, ensuring foundational knowledge from day one. To ensure long-term sustainability, we continue to track those metrics in real time for every procedures. This monitoring allows us for quick detection of outlier and guide further quality refinement. This combined action transformed the initiative from a pilot to standardized clinical practice. The result of our improvement initiative were both statistically and clinically significant. Following the initial set of intervention, we observed a 21% average reduce in the radiation dose, with strong statistical support. Further refinements and second rounds of the procedural improvement result in an even greater reduction, 30% compared to the baseline. This demonstrates the powerful of iterative quality control when combined with the targeted staff engagement. In the third quarter, we observed a plateau with only 1% change in average dose, which was not statistically significant. However, in the fourth quarter, a new record was achieved, a 31% decrease in the dose compared to the prior quarters, validating the enduring impacts of the embedded safety practice. In the follow-up phase, several key insights emerged. First, the limited experience of the many operators has with biplane system means that initial improvement requires ongoing education rather than one-time training. The learning curve was steeper than expected. We also find that maintaining visual reminder on the machine was essential. Without persistent cue, staff compliance with the optimizing setting tends to decrease over time. Other observation was that after achieving the substantial dose reduction in the first few quarters, additional decrease become progressively smaller. This plateau highlights the need to set realistic goal and focus on sustained gain rather than chasing diminished return. Looking forward, the next priority was to formalize departmental diagnostic reference level to guide the consistent dose management and the benchmarking. To conclude the initiative, we developed a precise and replicable framework for sustaining radiation safety improvement. First, every new staff member to operate the biplane system undergoing structural onboarding training focus on the radiation safety principle. Continuous monitoring remains a cornerstone of our approach. Routine dose tracking allows early detection of trends, ensure adherence to optimized parameters, and preventing regression. We summarize our approach as a simple but powerful equation. Radiographers' expertise combined with CQI tools and strong radiation safety knowledge direct translate into safer outcome for both patient and healthcare workers. This formula serves as guides for future quality initiative in interventional radiology. This is a reference used in this project. So this reference are guiding our methodology and analysis. Their findings underscore the importance of the leadership engagement, systematic monitoring, and staff involvement principle that shape our own project design. This source, combined with our institution's internal data, allow us to create an evidence-based strategy to reduce radiation exposure while maintaining procedure quality. So thank you for taking the time to engage with my presentation on the interventional radiation safety management. I hope the insights shared today can help guide similar quality improvement initiative in your own institution. I really appreciate the dedicated of my radiography team, medical staff, and administrative department who make this project possible, and their commitment to patient safety and clinical excellency drove every step of our success. I now welcome your question and look forward to the discussion. Thank you.
Thank you so much, Edward, for sharing the implementation that you have done in your department, and it seems work. Yeah. So
Yes.
before we go to the question and answer session, so for the audience in our Vidoctor, I just dropped the link for you for the evaluation. So feel free to give us a feedback on the evaluation and what you want us to do in the future webinar. And in the meantime, if you have any questions that you want to ask these two speakers, please feel free to add that on the chat box so we can discuss more in detail. And we have two questions from Dr. Jamari. Do you want to ask it or you want me? Yeah. But I think this
Yes.
is a good question. Yes. Please,
Sorry.
please.
Is there any questions from the audience so
No, right now
far?
we don't have. We don't
Okay.
have so far. We can start with your questions first,
Okay.
which is very
Thank
interesting. Yeah, I
thank
would
you
like
very
to.
much for both of you. So I start with Samuel. Your presentation is very, very good. I mean, I remember something about it long time ago, right? But now it's kind of refreshing and then eye-opening. But it sounds scary for as an interventionist. Do we need to know everything every time we went into the IR room? We go into the IR because in the real life, I walk in, right, step on the pedal, and then that's it. Maybe I use colorimeter, okay, try to put the scope all the way down, close to the patient, and be careful of the skin dose, right? And also protection myself and the team. But how much we need to keep in mind every day at least, right? That's all the basic of the physics, but how much we need to keep in mind? That's one of my
Yeah,
questions.
I would pick three things to optimize. If you want to pick three, let's go with these three. Collimation. Make sure you are looking at the field of view you need. The larger the field of view, more scatter, more dose, less image quality. Not good. The second is the pulse rate. Start low. If you're comfortable doing what you're doing at, say, 7.5 pulses per second, you're good. You're saving the patient dose. If you need more, go up 15, 30. That's really good. And then the third thing that you really want to control is time. And this is so how long you're pushing on the pedal. And that's kind of a little bit where now we're trying to deal with getting comfortable pausing and thinking, using the last image hold or the last floral loop hold. And that can be somewhat difficult. Sometimes people step on the pedal and they want to just go, 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 go. And that's not always the most efficient way. And so those are three really simple things, and that will help any operator really keep the dose low and the patient image quality the same. The other thing, there's a couple other things you can do. The next thing you can do is training. So some of the things that I talked about today, they're important, right? But we don't always have the time to remember them. But if we go and we have like annual training, or maybe every other year, we talk about, okay, where do we put the detector? Which angles are going to cause the most dose? And then we start to talk a little bit more about that. Then every time you walk in the room, those things are in the back of your head, but you just know, oh, okay, I'm going to put my detector here. I'm going to do this and this. It just becomes natural. And then the last thing I would say is, we talked about pulse width. We talked about all of these other really cool physics things we can do. Most of that is baked into the protocol. So when you buy a new system, you need to coordinate with the vendor to spend time going through those protocols you plan to use. So if you have a couple of very specific protocols, so you got the Dr. Chamry protocol 1, 2, and 3, and those are the ones you always use, then you can have them help set it up so you have really short pulse widths, you have the right pulse rate that you want, the right dose per pulse so you can see what you want to see. And those are things that after they're set, you never have to think about them again, as long as you pick your, favorite protocol. So those are kind of my steps. Really simple things, long-term things such as training, and then finally, always make sure the system works properly when you buy it.
That's great summary. Because I remember seeing the few of our IR, they step on the pedal without looking at the monitor. They say, "What's the point?" Right?
What's
I
the
mean, your
point?
eye
Yeah.
is not on the monitors, but now you step and start fluoroscope procedure. It's not the way it is. You need to
Yep.
make sure that your eyes already on the monitors before you start the radiation. And that's bring me to the second questions on, because everything you say it's on the display monitor combining, right? And then I'm not sure because I obsessed with the display monitors, especially when my radiologist requests very expensive medical grade display monitors. Do you have any comment on that part? On the kind of, okay, what kind of display monitors we should pay attention?
Probably the most important part is the size. Because if you're going to have it right next to the table, you can actually have a smaller monitor, and that's okay. But if you have a large operating room, a procedure room, and you have a lot of staff so that the monitor has to be pushed farther back, that especially if you're going to break up the monitor to have multiple views, then you really do need a large area format. And those are expensive. I'm not going to lie, those are expensive. And so if you don't have the budget for those large flex view, you need to make sure that it's closer to you or the table. And then that helps so that you can get by with a smaller. The second thing is all of those monitors are required to be calibrated so that when you have really bright lights in the procedure room, that it will change the grayscale. And if you turn off the lights, it will then change the grayscale again. So I recommend that if your technologist or physicist don't have the ability to check the calibration, when you have the engineer, the vendor engineer come in to do their what we call PMs or their preventative maintenance, when they come in, ask them specifically to check the light out, the monitor calibration. Always make sure that's calibrated. It's the same as when Tanya's in the reading room. We need to make sure those monitors are properly calibrated too. So that what you see in the procedure room is the same when you walk over to the reading room, and then you have to dictate your report. So we want to make sure they're exactly the same.
Because the reading room, actually, we can control a bit on the ambience of the room, right? But in intervention, sometimes you need brighter or light in the room for the procedure itself. It's kind of quite a bit difficult on balancing the backlight of the monitors to the ambient of the room. That's something, but great comment. Okay.
When you, if you're going to have a very bright procedure room, when you buy the system, you should ask them what the maximum luminance, which is the maximum light output that the system, the monitor can display. And you want something like 500 to maybe even 600 candelas per meter squared. And that means that you can have bright ambient lights and still see the most subtle grayscale finding, which, as you know, that's what you do in interventional procedures or cath labs. You're looking at very subtle gray. And so you need to make sure that the output is strong.
Okay, that's good. Thank you. So the next question for Edward. Okay, I'm lucky working in private practice, which has biplane. Okay, but many hospitals that I have seen, they say, okay, we can do one single plane, but use for both cardiac and body intervention because we don't have enough cases to dedicate a cardiac and intervention. Is there any specific recommendation? Because if you go for the big II, then the cardiologist complain. When you go for the smaller II, the body intervention complain. Especially in Thailand, we do a lot of liver body intervention, right? Anything that you think it will be the best compromise between the one size fit all?
Nowadays, when they have a three size, so-called big, medium, and large size. So, from my opinion, I would recommend still using the large size if you only have a single plane, because it can entertain all the surface, not just for the cardiologist. And on the other hand, but we have to consider about the contrast dose. So if you're using the single plane, we have the injection twice for the same anatomy to, for example, contrast dose. But if you just ask us to just have only the limited budget, So single plane, the fat panel should be better. So just Professor Brady said, we can collimate the smaller size to reduce the radiation dose for the patient, even cardiac case. But of course, you should say the angle for the cardiac case seems to be very tricky from their points of view. But I think they can accommodate their need for the single plane. Just what I say in my case, the cardiologists in my department, they use the single plane almost 4 years before they install the biplane. They still do it quite well, but of course, one of the good things for them is the learning curve is not that steep. So because a single plane, it only have to have the idea of a 2D to display. But if you have a biplane, you have to think about the ISO center. The most difficult thing for the cardiologists, if you're the young one, they don't have the experience to use the biplane. Why they increase the radiation dose for the patient? Because it's finding it's time to find the ISO center. This is one of the point. So they have to learn. So single plane is good. It's easier for the operator to adapt. That's what my points of view.
Okay, good. Thanks. Great point.
Yes.
I think we still don't have any questions from the audience on the chat box. Yeah. So can I continue with like the discussion that we were talking before the webinar start? That we were talking about like right now the fluoroscopy, like the machine that we have. It's not only in the radiology, it's also in the cardiology, it's also in the orthopedics, like for the operation and things. So I think like the main thing that we were discuss was about like, how we can like educate the clinician on this part, and as a radiologist or like a technologist and medical physicist, this is more like a requirement for us to learn about radiation safety and how to operate those things. How can we help with like the bigger healthcare system, since our machine is in other people's hands, and how can we get involved, and like what is your experience on those things? We can start with Sam and then like Edward, and also Dr. Jamari, if you have any comments too.
There are so many different users. There are physician level, technologists, and of course, there are, radiation trained radiologists or cardiologists, and then there are surgeons. And usually the ones that use it the most are not the most trained. And so we need online training. That's probably the easiest at our hospital. We have just modules that every year they have to review it. And they're not long, maybe 20, 30 minutes. Just keep it short so that they can go through the basic, simple steps to keep them and their patient safe. And two, just kind of like Edward talked about, the best way to make a physician excited about safety is tell them the lower the patient dose, the lower your dose. And if you if you remind them that how we image our patients directly affects us is helpful. And Edward talked about all of the procedures on how to reduce dose and tracking dose using dose monitoring, giving kind of reports back. So not real time, but mostly real time feedback to these physicians. Do they see, oh, here's what your dosing is, here's what your safety profile is. It helps them, I think, take ownership of the overall procedure process itself.
Yeah, thank you.
Yes, I agree that the education is very important. That's why in my presentation, because the radiologists, the cardiologists or any clinician, because even the vascular surgeon also use my DSA suite. So I will insist them, if they want to use the biplane, they have to have the education or training first before they come into the DSA suite to use the machine. On the other hand, just what Dr. Brady also said, we have the quality assurance committee in my team. So every 3 months, or every 3 months, we'll have the meeting to review all the radiation dose data. We will divide the different patient group for the different the clinician. So, for example, the vascular surgeon, they have their group of patient data. I will tell them the radiation dose compared with the last quarter. Is it increased or reduced? Is it better? So they have the mindset. And last quarter seems to be we have I assume their case is very evenly distributed. So I will tell them, oh, last quarter you seem to be the ratio a little bit higher. Is there any new staff coming in? Is it the training you need more, or you have any difficulty to manage your patient or even the machine? Just tell us. Our technology is willing to help you to solve the problem. So this is a mutually communication for all the team. So sometimes radiographer will have some observation for some staff they cannot do quite well. They will report to me or even to the head nurse. So we will do with a record and we'll tell their boss something like that. So oh, this staff maybe need more training before they do the DSA. So in China, the government also very strict rules to monitoring the radiation dose. So they also will do the annual check for all the procedures. Is radiation dose. They will ask us to present the radiation dose report for them. So if any special thing happen, they will ask any quality assurance report for them to read. So we have to present everything for them. So from top to down, we have a very quite so okay system to monitoring the radiation load for our patient. This is what we're running even in Hong Kong and China, something like that. Yes.
Yeah.
One more
Yes,
thing I want to mention is that sometimes especially some clinicians maybe come to the DSA not quite often, but they have the training, they have the mindset, but sometimes they forget. So why I talk about maybe one of the measures is putting some sticker at the panel or on the monitor. Remind them, please use the low dose for fluoroscopy. Don't use the high or medium. Just enough to be okay. Yes.
Yeah, like a reminder.
That's a good tip. Thank you. For Thailand, it's we are quite lucky that the government also give the regulation on quite strict. At least each hospital needs to have radiation safety officer, and lucky that we have the Dr. Tanya who also work both in Thailand and overseas to be part of the pushing team to try to make everything better. And we need to, for my hospital itself, for the RSO, the radiation safety officer, we need to try to make sure that they think of radiation safety as their DNA, right? So that's something that we try to put as their competency. But I'm also a radiologist in the administrative work, so I emphasize a lot. Sometimes they forget. So when I ask about radiation, they're thinking only the radiology department. They say where else? So need to list everything out and then make sure that everyone is in the mandate course for radiation safety training, because we have a strong program of safety, but not that much on radiation. But we don't want to scare people away as well, because when we went to do the kind of portable chairs in ICU, or the nurse run away, so we don't want that. So try to compromise the safety with the workflow. It's quite challenging.
Yeah. So anything else? Yeah.
No.
Yeah.
Okay.
Yeah, thank you so much. So I think I just feel like the education is not just at the level when you start practicing here. I think those education should be embedded very early. At least they're familiar with the medical term, what we are looking for, and what is the main things. Because I still remember when I was a resident, I need to remember all parameter that Sam were talking about before the exam. And when the exam done, I forgot until I remember those things when I need to do the fluoroscopy, VCUG, or G-tube placement in the patient, that I need to check on those parameter, like a pulse and like a last image capture, right? So I think those things maybe at least for the basic radiation safety thing that we should embed it in the education, like a medical school residency, and not only radiology residency training, but also if you are in the cardiology and you need to do that procedure or something, you might need to learn those things too. Yeah. So check if we have any questions here. We don't have any question from the chat box right now. So anything, any a last word or anything that you want to give to the audience so they can remember the optimization for the IR practice before we close this session?
No, just a reminder that I think in the end, you control the safety. You know, in CT, X-ray, mammo, all these other parameters, those are already built before you ever push the button to acquire the image. But fluoroscopy is very, very staff driven. And so if you own the process, if you desire to have a very low dose, good, safe procedure, then it will be better. So we just need to have them buy into the process. And that's the hope I think we can instill.
Thank you. Yep. Edward,
Yeah,
do you
I
have?
agree with Dr. Brady said. So just what we have a lot of policy and then also some quality control group or everything's policy, everything regulation we have, because it's everyone get involved. So no matter in the DSA suite, even in the OT, we install the angio CT or something like that. The technologies have the expertise to look after the machine, including the radiation dose, but sometimes we have good communication with the clinician, the nurse, so they also can give us some support how to reduce the radiation dose to the patient. Of course, reduce patient radiation dose to the patient, also reduce the dose to the staff. It's very important for them to understand that. Yes.
Yes, thank you so much.
Yes, I cannot agree more with Sam and Edward. How we're going to emphasize on our team that okay, the safer the patient, the safer the team and ourselves, right? Especially for IR. Other diagnostic equipment maybe not, but IR yes. We in the center with the patients. So
Yes.
thank you.
Yes. Thank you so much, our speaker, for joining us today and give us a very informative information and the discussion among us. And I hope that our discussion going to go to the community, and we learn on the same language, we learn on the same context and content, so that gonna make the community of the radiation safety is better. So before we end this session, I would like to show a couple things and promote the next session. So this is the evaluation code for the audience. If you watch on the Vidoctor, did you see? Yep. On the Vidoctor, and you want to give us, I want the feedback from you guys. So if you can give us a feedback on our topic, our speaker, and the future content that you need, that would be great. That we can have this thing more regularly and a target to the what audience in this a region need. And also I want to promote for the next section that we have it on the September 6th, that we are going to talk about the achievement quality and efficiency on the DR and CR, which is the big basket for us, that we are doing those the radiograph every day and in every body part. So this is going to be one of the good lectures that we are going to talk about the technique, the basic, and the future that we can do it better to optimize the radiation dose. And I also want you guys to save a date for the future webinar that we're gonna have it on the first Saturday on the October 4th and November 1st, that we are going to talk more about the how to optimization on the radiology technique. And this brings us to the end, and thank you so much everyone for joining us today and make the fruitful conversation and content for the radiation safety. Thank you, and have a good night, good day. Yes. Okay. Bye bye.
Bye-bye. Thank you so much.
Bye-bye. Thank you.
With your permission, may I close the session, ma'am?
Yes, please.